Mhm. 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 What's up, everyone? It is Tuesday night, 28th, 7:01 p.m. on the East Coast. I don't know why I didn't turn on any lights, but I don't know. Maybe it gives a nice nothing. It gives a nice nothing. It's strange. Um, if you're joining us, hopefully you are. Let us know you're here. Say hello and where you're from. And oh man, favorite book. I don't think I've ever asked for favorite book because I'm not a big book reader. I like to read, but I'm not a big book reader. I'm going to switch audio sources. Hopefully everybody can hear me. Let me check. Beth Carducci, camera, audio, AirPods. Looks promising. Okay. Hi, Beth Carducci. So if you're just joining us, welcome, welcome, welcome. It is Tuesday night. That means Community Conversations, June 28th, a week before the Denver conference, which I'm super excited about. Isle of Wight, England. Welcome, Lisa. That's awesome. Caitlin Stars, OCD sucks. That's a valid statement. I totally agree with you. It does suck. Hi, Kylie in Massachusetts. And also, what's your favorite book? Throwing it out there. We'll start in 30 seconds, just like to get people in the room and settled and situated. And then we'll have some good conversation. I have a story for y'all that you'll hopefully find relatable. If not, Mom, I thought you were calling me Black Beauty for a second. You're talking about the book. I saw Hello Black Beauty and I'm like, that's a weird thing to say to me. And yes, okay, the book Black Beauty. Thank you, Liz, i.e. my mother. Too many good books to choose from. Do you recommend any workbooks? Absolutely. There's some great workbooks for both. Well, for book wise, I recommend Freedom from OCD, John Grayson's book. It's kind of like the ERP Bible. And then there's some great ACT work. John Hirschfield's OCD workbook is excellent. I have, let's see, PTSD, self-compassion, ACT workbook for OCD, Kim Quinlan's workbook for OCD. As soon as Katie pops in here, I'll try to recommend some workbooks. I should Google that real quickly. Anyway, but yes, I will throw some out for sure. Sherman Oaks, my old neighborhood. Hello, hello, Bonnie. So if you're just joining us, welcome to Community Conversations. My name is Ethan, National Advocate for the International OCD Foundation, which simply means I'm here twice a week and I won't stop talking about OCD. Good conversation for tonight. We'll always be answering questions, but I have a story for y'all. Katie, what are some good recommendations of OCD ERP workbooks? I know ACT and DBT and self-compassion, but I'm blanking. Does John Hirschfield have an adult OCD workbook? And obviously Skyla is behind the scenes as always, and we'll put links to things as we go. So let's get some housekeeping out of the way so we can dive in. Nikki Bradley in Dublin, what's up? Oh, perfect. Freedom. Yes. Freedom Obsessive Compulsive Disorder. It's Jonathan Grayson's book. It's our Bible, if you will. Definitely around helping yourself navigate and understand OCD, along with exposure response and prevention. A Dog's Purpose. I can't watch animal movies. I don't think Katie can either. It's just because I'm always worried that something's going to happen to the animal. Yeah, Freedom from OCD. Yeah, I said that, Katie. I was thinking about more of a great ACT workbook. Yeah, Caitlin, we can talk more about that for sure. I totally understand that. So let's quickly get through some housekeeping. Community Conversation is intended to serve as educational content and is not intended to replace therapy. For treatment-related questions, please be sure to work with your local provider or contact a local clinician. The International OCD Foundation is not a crisis hotline. It should not be used if you're in distress or feeling unsafe. If you're in crisis or ever feeling suicidal or unsafe, please go to your local emergency room. Call 911 or call the Suicide Prevention Hotline at 800-273-8255. And thank you, Kylie, or Kate. I don't know why I filled it in, but Kale space Lee. You get the idea. We always want to be respectful and kind of others. That we try to create a safe space as possible for all of us to support one another. This is a conversation between us. I support you. You support me. We're a happy family. But no, in all seriousness, this is broadcast on almost all social media platforms and is public. So keep that in mind as you ask questions. But at the end of the day, we just want to create a safe space for us to support each other and talk about things. How is everyone doing tonight? Always start with that. Hope everyone had a good weekend and a good week. Hi from Mansfield. Oh, Mike Sizemore. I don't know why I looked at where you're from first. I hope you're doing well, Mike. Good to see all my friendly faces from friends and from Taiwan. I don't know that we've had Taiwan on here. That's exciting. Hi, Ann. Katie coming through with the suggestions on the books. Thank you, Katie. And hi, Deirdre. I know where you live. And hey, Eric Broach, what's up? And thank you also to somebody else just mentioned. So I thought somebody else suggested a workbook as well, and I don't know why I can't find where it went. All right. So first of all, how's everyone doing tonight? How are we feeling? What's going on? Yeah, there it is. Hirschfield's workbook too, but Kim Quinlan's new self-compassion workbook. Absolutely excellent. Hey, Ethan. Hey, Eric. How's everyone feeling? How's everyone doing? Caitlin, I can get to your question real quick, and then I have a story to tell tonight for once that maybe y'all can relate to, or at least some piece of it. But Caitlin, real quick, at 7:05 p.m. wrote, sometimes I find myself compulsing, and I do it like second nature, like almost subconsciously. So I relate to that, and I'm sure many people here do, Caitlin. There's a couple things to talk about. One is that compulsions can very, very much feel like second nature and almost feel involuntary. As you learn about OCD and you learn about the nature of compulsions, we learn that they are a choice. We choose to actively participate in a compulsion, whatever that is. When we're really struggling with OCD, either before treatment, if you've never had, wherever you are in your process, if you're struggling with OCD, or even after you've had treatment and you're struggling, I'll explain that in a minute. It very much doesn't feel like a choice. It very much feels like an I can't help it instead of I'm choosing or I won't do it, right? So that sensation, that feeling that there's no space between that obsession, that feeling, and then that compulsion is totally understandable and relatable. And typically it occurs when we're fused with our thoughts, right? And that fusion means that our thoughts are kind of right here in our face and we can't see anything. We can't see around them. We can't see anything but our thoughts. And so thought enters, and before we know it, we're compulsing. So it doesn't feel like there was any in between. And when you first participate in therapy, when you first integrate in therapy and learn about various therapy modalities and ERP and all kinds of, and so thank you, Marion, and all kinds of things, you learn that there is a cycle, right? And the cycle is enter obsessive thought, right? That is followed by an uncomfortable feeling. And I should say thought or image that is followed by an uncomfortable feeling. And then to satiate that discomfort, that anxiety, we participate in a compulsion, right? That relieves that anxiety and makes us feel better. And compulsions do that. They work, which is why we do them. But over time, they work less and less. And so that cycle becomes very quick and very fast, and it almost feels like they're one and the same. And sometimes it even feels like we miss the thought or the feeling. We're just compulsing, and everything just becomes one thing. But it really is broken down into those pieces. And so, what therapy attempts to do very successfully quite often is help you identify exactly until they don't work, referring to the exposure to the compulsions. And that's the problem, that the compulsions never if a compulsion satisfied at one time and you never thought about it or worried about it again, then great. But the reality is they stop working. This is a weird, not a weird, I always hesitate to use this analogy, but I used to be really addicted. That's a weird word too. I used to be really addicted to intervention on A&E, which was those individuals that had drug or alcohol addictions and how they played out. But doing compulsions to me was very analogous to sort of heroin, in the sense that everybody would talk about getting that first high of heroin and then chasing it over and over again. And obviously the more you use, the less effective it is. And you keep using and using, and you need more and more and more until it barely does anything and you're using all the time. And that's essentially, I relate to that as the same as OCD, which is that first compulsion is like, oh gosh, it feels so much better. And then you're constantly chasing that relief again until at a certain point, compulsions just don't work. And you're left with just a lot of pain and agony. So, the whole point of therapy is to separate and identify. So first, I'm having an obsessive thought, and that creates a discomfort and a feeling, right? And I don't like that feeling. That feeling is icky. Maybe I don't like the feeling. Maybe the feeling further tells me or sends a message to my brain that the thought that I'm having is true, because if I'm feeling it and I'm thinking it, right? So we want to experience those things and understand that we can't control those things, and then take a moment and a pause and recognize therein lies the choice, thought, feeling, choice, compulse or not compulse, right? And that's where all the skills and tools and everything else, hey Gentile, good to see you, everything else comes into play, right? So you're definitely not alone in feeling like they're one and the same. I know I went a year basically saying like, I don't understand, I don't understand how, sorry, was reading I don't understand how you say it's a choice. It's not a choice. I just do it. I mean, I can't help it. And, I finally learned that no, it is a choice, and it feels like I can't, but it's in a really, I won't, I'm choosing to do this. And so slowing that process down and being able to find the places where you can make choices and why you make that choices. So Caitlin, you're totally, I think, understood. And I think everyone here is or did go through that and has, and I'll share my story in a minute, and you'll hopefully be able to relate. So yeah, you just sort of, you talking about thought cognitive fusion. Well, the fusion I was talking about, sort of this idea of fusion and diffusion, which is an ACT skill, where you try to diffuse yourself for your thoughts. So yes, cognitive fusion and diffusion. But at the end of the day, I was just acknowledging that it can feel like it's not a choice, but once we get engaged in therapy, we do learn that compulsing is a choice, and we can choose not to do it. That's a really hard choice, by the way, just so we're clear. Very, very hard choice. Laura, I'm sorry to hear you've been stigmatized again. Let's definitely talk about that if you feel like sharing. And Ethan, why don't you just share the resource book link on the IOCDF website? The general tab has a lot of workbooks. That's a great suggestion. We can definitely do that. And we just did. So thank you, Skyla, for that. And thank you for that suggestion. I appreciate it. Marion, thank you for your advice. I love your programs. Liverpool, UK. Oh, I love Liverpool. Beatles. I mean, what? Anyway, so let me share a little bit about, and thank you for sharing that, Caitlin. I appreciate you. And if anybody has thoughts on Caitlin's, and as always, feel free to ask questions and anything else that you want to talk about tonight. But I'm going to share a story, which I haven't done in a while. And I want to share this story because, as you know, I've had a rougher few months than usual in terms of my own OCD. And I think, if you were joined in April, I was talking about sort of this neurology situation with my tongue and kind of dealing with that. And, a lot of somatic OCD, meaning I'm experiencing a lot of physical symptoms that I'm then catastrophizing. And so I wanted to talk a little bit about this because I always want to be transparent. I never want to be an advocate that comes on and just seems like I have it together all the time and it's perfect, because that's not real for me. No, I don't speak for anybody else, but that's not real for me. I'm grateful enough that management and maintenance of OCD can look like long periods of time where life is really, really good and OCD doesn't get in the way, and I can really count on one hand the amount of times that OCD has gotten in the way in the last, 5 years, 6 years, 7 years. But it does sometimes in bigger ways than it has. And last week was definitely one of those ways. So yeah, I'll speak to that, Caitlin. So, for some reason, well, not for some reason, I've been really sensitive about sensations in my body lately and health anxiety. Now, whether that's COVID, whether I am, and I used to have a lot of health anxiety as a kid, and it kind of disappeared for a long time. And I don't know that it came back with COVID per se. It used to be that my health anxiety, and I probably don't meet diagnostic criteria for health anxiety right now, because my health anxiety, the anxiety around my health, isn't particular to I'm afraid I'm going to get something, but not experiencing a symptom. For me, I'm experiencing an unusual symptom that I then catastrophize. So I was telling my therapist this, and she's like, well, you have somatic symptom disorder. I was super excited that I had a new diagnosis because I haven't had a new diagnosis in 4 years. So I was like, this is great. Like, just keep it, like little badge on my belt and have a new diagnosis. Super excited about that. I'm kidding. And I'm not kidding, because at the end of the day, a diagnosis is great, but the treatment is exactly the same. So at the end of the day, I still want to live a meaningful life and have a full life. And So, you could give me 10 more diagnoses as long as I'm doing what I need to be doing to have a beautiful life, that I could care less, honestly, about what the diagnosis is. But I will say that about 2.5 weeks ago, I started to notice a fluttering in my chest. And I don't know if I felt it before or not, but I kind of dismissed it. And I'm really good with distress tolerance. All is, sorry, I get distracted easily. Like somebody's texting me. I'm really good with distress tolerance up until a certain point. And please comment as I talk. Let me know if you relate to this. So, and I did the same thing with my tongue, and I've done the same thing with other things. So I started getting this weird fluttering in my chest. I know what panic attacks feels like. I know what anxiety feels like with your heart racing and things like this. This wasn't that. And I said to myself, that's weird. Okay, we'll ignore it. I'm sure it's nothing. And for me, I can do that up until a certain amount of time. And after a week or a week and a half, my brain goes, oh, this is still happening and it's bothering me. And if it's still happening and it's bothering me and I haven't been paying attention to it, I've been engaging in life and doing things that are meaningful, well, then something must be wrong, because why is it still happening? I've never felt it before. So, of course, I start Googling, which is the best thing you can do. That's a joke. That was complete sarcasm. It's the worst thing you can do. Start Googling, read all the things, and I start testing things on my Apple Watch to do the ECG on my Apple Watch. And I start seeing these sort of downbeats in my Apple Watch. So, yep, Dr. Google, exactly. So I send it to my doctor, and I go, here are some ECGs. This is what I'm experiencing. And it comes back and he's like, oh, you're having PVCs, which are premature vascular contractions. And apparently they're very common, and most people don't feel them or do feel them. And they feel like a skip in your chest, and sometimes they can hurt a little bit. And in general, can be caused by stress and anxiety. So he's like, if you're having them and they're bothering you, here's a beta blocker, but otherwise, don't worry about it. It's like, don't worry about it? What are you talking about? This is my life. This is my heart, And I went down a rabbit hole pretty quickly of experiencing these. They only happen at a certain time. They always happen in the evening when I'm relaxing. They didn't happen before. Why didn't they happen before? Why are they just happening now? If it is stress and anxiety, why can't my body? All the what if statements, right? And so I make it through the weekend, and to a point where actually Katie took away my Apple Watch because I was constantly doing ECGs on my watch. See, you guys relate. So good. I'm glad, and I said, Katie, she's like, I got to take it away. She hid it. I found it. She hid it again. It was one of those situations. So Monday of last week, I went to urgent care. And I try to do my best. It is so hard sometimes to suss out. There are various symptoms and subtypes that feel difficult or more challenging. And for me, in these cases, I'm like, well, I'm having a real symptom. It's something I never experienced before. It has to be valid for me to want to go to the doctor and checked out, right? That seems reasonable. So I start, and then if I check in, there's still part of my brain that's going, yeah, but maybe you're overreacting, and maybe it's OCD, and your doctor did say it's nothing to worry about. Exactly. It's very challenging. So I went to the urgent care because I didn't want to go to the ER. And one thing I do is I don't offer more information that I'm asked, because I don't want to inadvertently ask for reassurance. And it's just a good practice to have when you go to the doctor. The other thing that I don't do, which I used to do all the time, was I used to oversell something so I could get all the tests to make sure I was okay. So, if I was having weird feelings in my chest, I would go in and say, oh my gosh, I have the worst pain in my chest. So I could get in, get seen, get all the tests. I'm not interested in that anymore. So I went in and spoke the truth, which was all it was. They did an ECG. It was normal. They checked it out. And the doctor came in and said, look, PVCs can be normal. They can be brought on by stress and anxiety. Are you stressed and anxious? And I'm under a lot of stress with work, so that's not unusual. The tongue thing was stress, so clearly my body isn't handling stress well right now. And so, now, wait for the rest of the story, Mike. So, so she goes on and says, I can't give you total certainty because the ECG misses things and it won't detect this and it may not show that. And, if you really want to know, you know, you can go to the ER and they can get a blood test and check for this protein and do some other things. You know, if you really want to know, I can't give you that certainty. It doesn't look like that, but you know, that's it. So I'm not going to sit here and tell you to go to the ER. I don't think you're having an emergency right now, but you can go. But then she stopped and she said, but with that being said, if you go home and you have any one of these 12 symptoms, go to the ER. Do not come here. And, you know, shortness of breath, pain in your chest, this, that, the other thing. And it freaked me out. I got in the car and there was so much going on in my head right now. So much going on in my head because on one hand, I was trying to justify everything. Well, she said this and she said that and she said this, and I am feeling that. It's real. I'm not making it up. It showed up on tests and things and you know, and I called Katie and I was like, you know, I don't know what to do. And I agree, it usually goes on away on its own, except it had been 2 weeks and I still have them now. But anyway, so I said, I don't know what to do. Like, this is what she said, and this is what they said, and this is what I should do. And, you know, and I put Katie in a tough spot to have to, you know, really irk me, right? Like challenge my thinking. But at the same time, you know, she doesn't, you know, God forbid if she's wrong and, you know, dives into her moral scrupulosity issues. And like, what if I give Ethan advice and then something happens? So I decided to go to the ER. And in retrospect, I can see where the choice was. And we talked about choices earlier. In that moment, I don't know that I could see it. I did notice my brain going, you're overreacting, not overreacting. That's not the right word. You're really getting stuck on what she said. And I did check in with Wise Mind, and it didn't feel like it wasn't an emergency. I did not feel an emergency, but that certainty that the hospital could give me was too juicy because I was so uncomfortable and so worried, and so much is at stake because life is going really well and I'm getting married and work is going well and I'm in love and advocacy is amazing and I have friends, right? So the stakes feel right. So I went to the ER. And I went to the ER and, you know, I wasn't there too long, actually. I was there about 5 hours and they ran a bunch of tests. And then they put me on a heart monitor for about 2 hours just to observe. And on that heart monitor, I had about 3 or 4 PVCs and everything else came back normal. And of course they said, you know, everything's normal. You know, you should follow up with a cardiologist, but you know, you're not having an emergency and it's fine. And I said, but did you see the PVCs on the monitor? She's like, yeah, you know, unless you're having 10 and 30 seconds, we don't really care if you have some, you know, blah, blah, blah. No, they didn't do ultrasounds. They did x-ray, they did multiple ECGs, and they did multiple blood workups. And so they, you know, released me and, but they said, oh, by the way, but I looked on the thing because they send you, sorry, I'm a little tired as always, long day. They sent me home with a sheet and it said, follow up with cardiologist no later than 3 days. Oh my God, they want me to see a cardiologist in 3 days? Crap, something must be up, even though they said. So of course I get in the car and what do? Call the cardiologist they recommended. They can't get me in for a month. I'm like, oh my gosh, I can't get in for a month. I then go onto one of those websites where you can like talk to a cardiologist, like pay $45 and talk to an expert. And like, so I'm sitting in the ER parking lot. So and I'm sitting in the ER parking lot. I just got out where they were like, we're pretty sure you're good. Every story in my life that's happened where a hospital has said that to somebody and it didn't work out is playing through my mind. Every celebrity, every friend, every family member where they went to a doctor like, no, you're fine. And then they went home. That's all playing in my head. And I talked to this doctor and we text and I go home. And needless to say, the rest of the week was very challenging last week. I actually scheduled an extra appointment with my therapist. Exactly. They have to cover their ass. But in covering their ass, Beth, and saying, we can't assure you, and we can't do this, but like they're covering their ass really challenges my OCD because, I get it. Of course they're going to cover their ass. So I came home and it was really challenging. That night, my heart was going nuts. And the next day it was going nuts. And then a few days later, I was okay for a few days. Then it came back and it was really bad. And I wanted my watch. And it was this cycle. And I had a really good session with my therapist on Thursday, and we just talked it all through and we came up with a game plan. And, as it got further away from all of that, even though I had a rough day on it was either Thursday or Friday, I had a really rough day. I kind of just started I finally was able to start to see it for what it was, embrace it for what it was, which is, yes, I can keep seeking reassurance. I can keep getting questions answered. I can keep getting tests. I scheduled a cardiology appointment for the middle of July. That was the earliest they could take me. But in reality, I'm never going to have certainty. Doesn't matter how many tests I have. Number two, 3 doctors have told me it's most likely stress and anxiety. Could they be wrong? They could be. And at a certain point, I went down a rabbit hole that I hadn't gone down in a very, very long time. The last time I went to the ER, and I'm not shaming myself, but the last time I went to the ER that was more OCD and more anxiety and less needing to go was, honestly, before I got better. I've been to the ER twice since then, but I needed to go. So I had some stigma around that. I had some stigma around that decision. I felt a lot of shame and guilt around letting it get the best of me. Since then, I've given myself a lot more compassion and been like, it was hard to see the forest through the trees, right? And that's okay. But I really started this weekend embracing this idea of the discomfort around my chest, the pain, if there's this, if there's that, whatever comes up, because I have to remember to put my mental health first, and the other rabbit hole is way more detrimental than whether there's something wrong with my heart or not. The reality of it is I know deep down I'm fine. Doctor said I was fine. I have to trust that, and whatever uncertainty that's left, so be it. And that's where I'm at. And I had a really good weekend. And, actually right before I got on here, I got a couple flutters for the first time today. And I was just like, oh my gosh, I have to go on and do this. But it's very freeing to re-embrace and stop the compulsing. And I got my Apple Watch back. I have not checked today on anything. I'm not interested in checking. I know what they are. I have a plan in place. And, I was very quick to go ahead and schedule another therapy session with my therapist because I take it very seriously, and I want to make sure that I have all the bases covered, and that I have a plan in place, and we're continuing to, work on that plan. Because in reality, in those moments, I have a plan, but I can still do what I want, right? And so, my therapist can suggest X to me, and I can go, yeah, that's a great idea, but then, give in or whatever. One of the things that we talked about, was this idea of stakes in life, meaning, and I brought this up earlier, but my lack of willingness to tolerate distress around my health has a lot to do with where I am in life right now. I'm experiencing things that I've always dreamt of. And because of that, I feel like I have a responsibility to others and myself to be vigilant, to make sure that I'm healthy, because I'm responsible for things and people are responsible for me. And I can see a future, and future's not guaranteed, but there's so much more that it feels like there's so much more at stake that I can't take a chance, when in reality, there might be more at stake, but that's even more of a reason to embrace the uncertainty, embrace the discomfort. And, I didn't do that as well as I should have last week. But I tell you this story, because it's so important for people to know that, when you see us on lives, and because we have these titles in front of our names, doesn't mean that OCD still doesn't come knocking on our door pretty violently sometimes, so that's number one. Number two is, the reality is OCD will take away my life long before, heart or physical or any of the things that I'm afraid of happening, and I've already been down that road, and I know that. Already been there. I know that, So, so I think that, and being proactive now and looking at new ways. And the last thing was, to be able to see a pattern this last year that I haven't seen in a long time, where even though the things were real, they were real somatic physical symptoms that weren't normal. Still, I can look at this year and go, well, there was that one in January, or I could look at last year, in the middle of summer and go, well, there was that one. And then there was my tongue in February, and then there was my heart. And okay, body does weird things under stress. Things are happening, but I can also see a pattern, right? So it's like I can't ignore that there's a pattern and the way I'm responding to that pattern. So no one's invalidating the feelings and suggesting that I should or shouldn't. And in reality, I'm rambling, I apologize. In reality, if I had sent the email to my doctor and it had ended there, that wouldn't have been compulsive. Hey, I'm experiencing these things. What do you think? He wrote me back, probably nothing. Stress, anxiety. Here's some beta blockers in case. If I'd have let it go there and just been like, okay, I'll take his word until I have more information. I never really got more information. There were never really more facts that presented themselves. Nothing changed. I was still having the flutters, but no other symptoms presented themselves, nothing else. It was just, it didn't go away. And my tolerance for coping with it became less and less and less until I finally just kind of like, okay, I need more certainty. So I know that what I'm feeling isn't dangerous. So being able to see the pattern, hey, Leanne, being able to see the pattern in my own year further inspired me to really take a crack at this. And that's why, I joked at the beginning about having a new diagnosis, but, I told, oh, I'm sorry to hear that, Deirdre. I agree with you, Valencia. I told my therapist, I said health anxiety. She's like, it's not health anxiety, it's this, and whether it's part of OCD or not, it's an anxiety disorder and you treat it the same way. But seeing the pattern in the year was really a game changer for me, zooming out and kind of going, valid, but you're still responding to this way. And so I wanted to share the story with you for all the reasons I just said. Hopefully you can relate. I know a lot of people are relating in many ways to health anxiety and or somatic stress disorder, whatever it is. It really, again, the diagnosis doesn't matter. It's all sitting with the discomfort and uncertainty and using whatever tools from whatever modalities of treatment you use. That was important for me, and to let you know that you're not alone. We are in this together. And I'm still having more good days than bad this year by far. If I can end up in the ER and be working and totally focused and value driven, a week later and even, days later back to working, that's a win. I'll take it. I'm not going to beat myself to death. I'm really not. You can only do what you can do. So, hopefully, there were some takeaways for you in that story, feeling less alone, understanding that advocates, I know it's obvious, but I don't ever want to be on here presenting like everything is chipper all the time. We say it, but I wanted to give you a real experience perspective of what the last week was like. But so far the week's going great. I still have the feelings. I'm putting them in the just letting them sit here next to me and let OCD scream and move forward. And at the same time, also trying to take time for myself and be less stressed and work on that, because that is something I can be proactive about. So let me back up and try to get to some of your questions. So at 7:21, I'm sorry, I can't pronounce your name. SVT said, is there a cure for it? Really? I assume you're talking about OCD. And right now, no, not that we know of. OCD is chronic, but that doesn't mean we've had multiple conversations about chronic versus cure. And I never want people to feel, people to feel disappointed that there's no cure, in the sense that, we'd love a cure. That would be amazing. But living a life in management and maintenance is still pretty amazing. And the level of wellness that you're capable of reaching and attaining is beautiful. And so even in the space of a lack of a cure, It's extremely treatable, even though it's a pain in the ass to treat. It's difficult. It's not fun, but it's a highly treatable condition, and you can really live a full, meaningful life with it. And, I say this all the time, more good days and bad days, but, before I got better, I spent a lot of time in urgent care, and I spent a lot of time in the ER. And, I think I made 4 trips to the ER the week before I was put in a psychiatric hospital because I was so afraid things were wrong with me. Since I got better in 2011, this is the first trip to the ER that was, I would say, more based around anxiety and OCD than in reality and facts. I'll take that. So there may not be a cure, but I hope that's inspiring, because to have gone from literally 20 years of urgent care, oh my God, blood tests and blood tests and blood tests and checking and fever and this and that and the other thing, and ERs and what if and fake. I mean, like, that life to, in 11 years, I went one time. I don't know. I think I should be self-compassionate around myself, and I think that's a huge win. So no cure as of yet, hopefully coming soon to a lab near us. But in the meantime, there's some really good modalities of treatment and therapy, and you can live a really beautiful life. And thank you for all of you that commenting on your own issues with health anxiety or heart. It really feels good and nice to hear some of the well, that I'm not alone, if you will. 7:24 p.m. Patricia asks, hello, Ethan. How do you make the difference between confession, compulsive behavior, and an exposure? Could the difference be in the urgency? How do you make the difference between confession and an exposure? Well, I think I understand your question, Patricia. Thank you, Skyla. Like, the difference between a compulsive behavior and an exposure. Well, I mean, an exposure should never be a confession. I'd like more. I don't know if you've given more insight later on. Could you be more specific, maybe, as it relates to you? I just want to make sure I understand the question right before I answer. I think I understand what you're talking about, because I know what a confession is. And designing exposures around confessions. Typically, the exposure for confession would not be not confessing. So if you feel the need to confess as a compulsive behavior, the exposure would be to do whatever the thing it is you do, and then not confess as the exposure, unless that thing is not healthy or whatever, in which case, so I'd love a little bit more insight, Patricia, and then perhaps we can talk about it some more. Let me quickly get through to some more questions, because I know I talked for longer than usual. I have a question: can severe OCD cause seizures? Not a doctor or clinician, not that I know of. I've never heard of that. I've never heard anyone say that or talk about it or connect that in any way. So I'm not a medical expert in any, but my answer would be no, they can't. I've been medical assistant 30 plus years. Thank you for that. Yeah, I guess a lot of people with anxiety have PVCs. Let's just all take comfort in that fact right now. Apparently, it's a thing. Let's see. Leanne, did I miss somebody's question? I feel like I thought there were more questions, but maybe I didn't. If not, I'll jump to Leanne's question. If I missed your question, let me know. So Leanne asked at 7:34 p.m., does accepting OCD treatment automatically mean we must accept hospitalization and or medication, or do we get to decide that? What a beautiful question, Leanne. So OCD treatment, right? We talk a lot about handing over the keys, or this radical faith. We have to trust the process, because I think that we as individuals with OCD can complicate treatment an awful lot by overthinking and questioning and arguing and trying to figure out. The reality is, I don't think it's black or white, and I don't think it's yes or no. I think the answer is gray. Therapeutically, so from a therapy standpoint, ERP, ACT, DBT, ICBT, we can talk about that. I've been learning about metacognitive therapy since the town hall. Not ready to go into it today, but it's another conversation. I think for those therapies, we should release control as much as possible, unless you feel that they interfere or they are a direct violation of your core values or faith beliefs. But ultimately, the things that we're asked to do in therapy are scary. and can feel scary and feel wrong and irresponsible and immoral. But the whole goal of therapy is to get us better, not hurt us. So for the most part, you should trust that. Hospitalization and medication, I feel, is a little bit of a different animal. I can only speak from my own experience. For most of my life, I fought medication, and I was on it since I was 14, and I've been on every SSRI known to man multiple times. And every time they wanted to increase it, I was very against it. I didn't like how it made me feel. I was like, no, I was very argumentative about the process. When I got really, really sick and ended up in a psychiatric hospital, they start you at the highest dose there. They don't care. They put you in a hospital and they want to stabilize you, right? And I was off almost all my medications at that time. And so, I didn't have a choice in that sense. And I was so desperate for help. I didn't fight it. I was just like, I have nothing to lose. I feel like this thing's going to kill me. So do whatever you want. And I think over the course of 3 weeks, I was on 3 different medications before, they gave me one that kind of worked. It was after that I reflected on this idea of sort of handing over the keys and realizing that I could actually tolerate a lot more pharmacologically than I thought I could. Anytime they raised it, I felt really crappy. And yet here I am, and they dumped 300 milligrams of something on me. And, sure enough, I was functioning. And so it's tricky. And I think at the end of the day, you have to check in with yourself. My only advice is this is I've never gotten this question, so I'm thinking through it as I answer. Only you can really know for yourself, but make sure that your choices are value driven. I know that's sometimes hard to know in the moment, no different than me choosing to go to the ER. But, as far as hospitalization, I'm not sure if you mean a non-OCD hospital, a residential program, or hospitalization. The work that I do with my psychiatrist right now is very collaborative, very collaborative. If she wants me to change something, we talk about it. I offer suggestions. I say things like, I think I need to work on my therapy harder. I think I need to use my skills better. Let me do that for 2 weeks. If that hasn't proved useful in 2 weeks, then we can consider moving it up. And it's been a really amazing collaboration and really successful in doing that. And I've kind of learned times where I've really had to surrender and let her do her work, and times when I've pushed back a little bit. So I don't know that it's an all or nothing question, but I think treatment is a word that encompasses a variety of things. It encompasses therapy, encompasses pharmacology, it encompasses other treatments like TMS or DBT or surgeries or things like that. I would argue that accepting OCD treatment means that you should accept everything. If somebody says you need brain surgery, I would be skeptical of that and seek second opinions and talk to folks, right? I think where acceptance really comes is in exposure response prevention, ACT, DBT, the therapy modalities, where accepting that uncertainty is really where the 100% of that lies. Everything else, I think there's a lot of, there's some maneuvering and some gray. That's just my opinion, so I'll be curious to what you all think. But great question, Leanne. I appreciate it. My computer just skipped and I lost my place. Okay, here we are. Patricia at 7:34 p.m. You said, Ethan, that you need to discuss a plan with your therapist. Do you feel sometimes that your therapist is telling you things that you already know and that you are just seeking reassurance? Great question. My thought process when I'm going through a hard time is to ask myself what my therapist would tell me. And 9 times out of 10, I know. And 9 times out of 10, I don't end up touching base with my therapist because I already know what she would say. And I've been with my particular therapist for 11 and a half years now. And I pretty much know everything that she would tell me to do. Sometimes it's good to hear. In this case, no, this wasn't reassurance seeking. It wasn't so much, I wanted to come up, and to Leanne's point, when I was sick, I had a health contract. So when I was really struggling and in therapy, I couldn't go to a doctor unless one of my psychiatrists or psychologists gave me permission to go. And that sounds crazy, but when you're going to the ER every day, you kind of have to put a fine line in the sand. When I got better, obviously the choice was mine. The choice was always mine, but in this case, I've been noticing, as I talked about, this pattern. And so I wanted to, instead of being reactive, in other words, oh my God, I'm experiencing this thing. Let me do what I know to do. And then let me reach out to my therapist and see, do you think I should go to the doctor? Here's what I'm experiencing. Like, what are some proactive things that I can come up with? What is a plan that I can, so for instance, so in this case, no, I was not seeking reassurance. I wasn't asking her if, if she thought it was dangerous or, if she thought it was OCD. What I asked her was, what's a plan that's more sustainable than what I'm using? So when these things happen, I can approach it in a healthier way, right? So we're starting to build it now. And it looks like step one, stop emailing your doctor. That shit doesn't work. It only gets me worked up. And I dive deeper into the hole. Number two, don't Google, right? And I already knew don't Google, but we just reinforced that. To me, emailing my doctor was a very in my mind, it was a very non-dangerous thing to do in regards to OCD, right? I'm not going to the ER, I'm not going to urgent care. I'm not even scheduling an appointment. I'm just sending an email. And if I would send just one email, then guess what? That would be fine. But I didn't send just one email. I sent 5 emails asking 5 other questions once he answered me. Then it looks like, okay, what from there? Well, if we decide with my therapist and I that it is something worth further exploring because I'm experiencing symptoms that are different or worse, then I schedule an appointment with my doctor. I don't ask for an appointment quicker. I don't try to get in it immediately. I simply ask for an appointment with my doctor. Whenever they can see me, that's when I go in. And it goes on from there and there. Obviously, there's an emergency, or I think there's an emergency. Of course, go to the ER, and I'll have to. And I said, well, how do I know? And I just have to take the risk. My big fear was, and you can probably relate to this, I said to her, well, what if I choose not to go to the ER because I'm afraid it's OCD, and then it's not OCD and I should have gone to the ER? And she's like, well, then that, yes, you have to take that risk that might happen. And that's true. And it's always been the case. So great question. I think there are times when you can seek reassurance from your therapist, but also argue that if you have a good therapist, they will know those times and not reassure you. But in this case, no, I was seeking different skills and tools to address something that I felt like I needed to be more vigilant on. So great question, Patricia. Kylie wrote, I struggle pretty severely with 7:34 p.m. also, Skylar. I struggle pretty severely with BDD. How can I try to learn to accept myself and stop the compulsion? That's a great question, Kylie. I'm going to ask you. So I could answer that, but I think you would be better served asking Chris Tronsden that, who is a therapist, lived experience, and has BDD. He is fantastic at answering these questions. Tomorrow is an Ask the Experts with Chris. I am not passing you off. I can definitely give you an answer, but I have less experience with personal. I don't have BDD. And some of the treatments are the same, but it's also a different approach. And can be a different approach and a lot more difficult. So I totally understand and give you so much credit for asking that question. And at the end of the day, the short answer is therapy, exposures, and there's other treatments that you can do. And BDD is treatable. And I know lots of folks with BDD that are living beautiful lives. So I will give an email out at the end. I always do, of my email address. And so, if for some reason you're not able to join tomorrow or you can't ask Chris directly, email me and I'll put in an email to Chris and we'll get some answers for you. But I want to let him answer first, just because I think he could do your question better justice than I can. But again, if you don't get an answer, then I'm happy to answer. But the short of it is, ultimately, therapy, treatment. Look at the resources on the IOCDF website on BDD, and sort of start there, and that'll give you a good base. But thank you for asking the question, Kylie. Denise at 7:35 asks, how do you deal with scrupulosity combined with other subtypes? Well, that's a great question. And, scrupulosity, whether religious or moral, can make other subtypes really pain in the ass. But the reality is that multiple subtypes can exist simultaneously. Whether that's, and really, if we're talking about moral scrupulosity kind of exists in everyone's OCD. There's always a little bit of moral scrup around there. If you're talking about religious scrupulosity, then that's a different conversation. But at the end of the day, if the scrupulosity is OCD, is entrenched in OCD along with other subtypes, then it's treated just like anything else with treatment. Exposure response prevention, acceptance commitment therapy, dialectical behavioral therapy, metacognitive therapy, and working with a treatment provider or accessing support. Scrupulosity can, this idea of shame and moral wrongness and guilt and feeling like a bad person, or a lot of it, it really exacerbates, and it feels like it makes treatment trickier, and in some ways it does, but at the end of the day, whatever your scrupulous thoughts are, it's still about embracing the uncertainty that they may be true. So if you're thinking to yourself, what if I'm a terrible person and I don't even deserve to get therapy or to even work on my other subtypes because of something I may have done or something that I think I may do, or just for having these thoughts, then it's still sitting with the uncertainty of those thoughts, being willing for them to be true and address the other subtypes as well. So we treat them just like any other subtype. So it's all about embracing the uncertainty and being willing to live. First of all, being willing to identify that those are thoughts, just like any of the other subtype thoughts, and the feelings associated with those are just feelings. Even with real event OCD, meaning there's something in the past that you feel guilty or have shame around, and what if you're going to do it again and you feel like a bad person? It's still the willingness to sit with the uncertainty that those things may or may not happen. Who you are may or may not be true. We can embrace the fact that it's probably OCD and try to sit with the discomfort that it may not be, and get lots of skills and tools around that. So hopefully that was helpful, Denise. And you're welcome for being vulnerable. Thank you for that comment. And you're welcome, Eric. Thank you. And I thank you, Chad. Thank you for all the love. I appreciate it. Hello, Ethan. Thank you for, all eyes on P, 7:36 p.m. Thank you for doing these live chats. I wanted to know if compulsive staring is coming up among you and your colleagues. Great question. John Grayson is doing a fair amount of research, or was doing a fair amount of research on compulsive staring. There is a live stream that we did on compulsive staring. It might have been 2 years ago. It might have been last year. It's not talked about often. Don't ask. I'll tell y'all later what that is. It's not talked about too often. Definitely email me about it, but we'll see if we can find the compulsive staring with John Grayson, and he had one of his patients on that has that as well. It's a really good town hall on it, and he definitely check it out. And then, but it is coming up. We've talked about it a lot, but it's still a very under-researched, underexplored subtype and symptom, and how and what and why. And if it's something that you deal with, be more than happy to connect you with some people that are working in that space, because there are not many of them right now that are at least talking about it. So I'll give them my email at the end. And but thank you. Great question. Oh, Katie said, we're doing a talk at the virtual conference on this, having OCD and living a joyful life anyways. Thank you, Katie. Caitlin wrote, management and maintenance seems nearly impossible. It may seem nearly impossible now, but I'm here to tell you, and people will also tell you on here, that it is not. It is not impossible. Maintenance management is completely possible. And I know in the moment how hard it feels. And I never say any of the things I say with anything but the utmost humility and respect, because I know how hard it is. And I'm not saying your journey is my journey, or that we share the same. I just know how hard it was for me, and how sick I got, and it's how sick I was, and how long it took me to find a life where I could live it in a meaningful and joyful and full way. So I know when you're struggling, it feels nearly impossible for all the reasons that we've talked about today. And you can look at my last week and say, see, you can look at it two ways. You can look at it and say, see, it's still plaguing you, and look at that OCD like it never goes away. Or you can look at it and go, wow, look at you doing a live stream tonight and having a good time and being present with your people. And you had a great work week, and you had a big work day today, and you're going to make dinner with your fiance after this. And right, there's all kinds of ways to reframe it. I'm telling you that maintenance and management of OCD is indeed possible. And I'm sure there are lots of people in this group that will be happy to tell you the same thing, that they've experienced it themselves. And if you take anything away from me in this moment, Caitlin, know that it is possible. It is possible, and it is possible for you. I don't care how you feel, what you're thinking. If you think your OCD is different, special, unique, no one else has struggled like you, all the things that I thought, right? Not saying anything that I didn't think. I'm letting you know that, it's all possible, and you can live a pretty damn good life, and still have OCD. So just worth saying. The conference is next week. It is the 8th through the 10th in Denver. We're super excited. Listen, great question to throw out. We have a few minutes left. Who's going to the conference? Raise your hand, say yay. And if you're going and we haven't met in person, I would love to meet you. So that would be awesome. I think Schuler, I said that correctly, at 7:38 p.m. said, any suggestions for hanging in there and sticking with the OCD treatment when there's a trigger that lasts a long time? Consistency and patience. And it's hard, but putting your values first, understanding why you're choosing to go through the treatment in the first place. What are you losing out on? What are you missing? What's important to you? What do you want to dive back onto? What do you miss most about your life? What do you want to do that you never did before? I can tell you things that I was triggered on, and when I was in treatment, actively in treatment, that I was triggered on for days or weeks, and my anxiety was a very high for days and weeks. And you're like, oh my God, is life going to be this hard to live? Because if it is, screw it, right? But it's not. It really is not that way. The more you stick at it, no matter how long it takes, one day it's like that weird pain that you had, and then one day you're like, that was gone. I wonder when it went away. Treatment kind of happens like that. One day you kind of go, well, this just got easier. That's cool. So I would highly suggest sticking with it and hanging in there. If you had some wins already with treatment, then it works. And if there's things at the higher part of your hierarchy or the things that you struggle with more, keep at it. Keep willing to embrace the uncertainty. Keep willing to dive in and get dirty, and giving yourself grace and patience and lots of self-compassion around the process. And it's a marathon. It's not a sprint, but you will get there. Is skin picking around fingers OCD? Is a co-occurring condition. It's part of body-focused repetitive behaviors, or BFRBs. There's a lot of good content on the IOCDF website about BFRBs, and specifically skin picking. And you can really skin pick anywhere. I know people that skin pick around their fingers. So it's a co-occurring condition. It has a separate diagnosis, but it's under the OCD family, and there's lots of things that you can do. I can tell you now, and I don't do this, I just know a lot of people that do it. If you find yourself skin picking, you don't realize you're doing it. Keeping your hands busy is a great way. I know somebody that knits all the time. They've made 700 winter hats to keep from skin picking, but they knit. That's a joke. And I'm not joking about the skin picking. They're always knitting, and I have a lot of winter hats. So that's awesome. Origami, fidget things to just kind of keep your fingers and hands busy until you kind of reorient your behavior to stop, and just being aware and noticing, similar to, coming back to the present moment and being mindful when you're doing it and stopping yourself, right? Even if you go back to doing it again, if each time you can recognize that you're doing it and stop yourself, eventually those times will get fewer and fewer, further and further between. So, but please look up BFRBs. There's some great support groups, a lot of people talking about it. You're definitely not alone in that. And it is a common occurring condition with OCD. We got 1 minute left. I'm just going to quickly scroll down. Oh, it already addressed it, and see. Oh, thank you, Patricia. I just wanted to see if I was just reading. Sorry, I was reading Leanne's comment, 757. She wrote, at Ethan Smith, I feel the opposite when I come here and hear the community's struggles with their subtypes. I think, golly geez, mine seems mild. I should just get treatment and get rid of it. Do it. Can I hold you to that? I would love that. And then come back and tell us how it went. You should. Absolutely. I'm going to hold you to that. I'm going to screen cap that. And, everybody's got their own journey. And I know lots of folks with mild OCD that, go into treatment and they really struggle with it. And I know lots of folks with severe OCD that go into treatment and they crush it. And I know lots of folks that land in the middle. And reality is everybody's on their own journey with OCD. We can't compare our journeys to other journeys. We can't, because, just like it's not fun to compare our lives to everyone else's on social media. It's not helpful. It doesn't benefit us. It's just really about our life and our journey and our experience with OCD, and not setting benchmarks around other people. It's our race, and really, we're up against our OCD, and that's our only, opponent in this, not anybody else. And so focus on your race, focus on, what you need to do for you. Give yourself lots of love and self-compassion around it. Communicate with your therapist if you have one. If you don't, try to access therapy. We're all about helping people, access treatment and therapy and getting them where they need to be. I know it's hard. I know it's not easy. We could go on a whole conversation about accessing therapy, and that's why we do what we do. But yeah, in some cases, and that's also okay too. You go to an addiction meeting, an AA meeting, or a Narcotics Anonymous meeting, or a GA meeting, whatever you go to. I went in my 20s and for gambling, and I went in and I was like, oh my God, I'm like not nearly as bad, and that was inspiring to me. That inspired me. That was like, okay, I got this. I can do this, right? So like, that's not necessarily a bad thing. It's like, if you're already halfway through, finish the race, then finish it, Leanne. I support that. I'm just going to quickly make sure I didn't miss anybody's, because I know I asked some people for some additional information, and I don't see anymore. Well, we're 8:02 p.m. I want to be cognizant of everyone's time. I hope everyone found this helpful, and thank you for letting me share more than I usually do. Oh, yes, fingers. Okay, right. Sorry, my bad. Thank you for reminding me. So a friend of mine sent me this, and it's super weird, and I just fidget with it all the time. So I think it prevents skin picking, perhaps. But it's this weird squirrel. Sorry, everything's reversed. And it's like, it just goes on your finger. And I think it's for Zoom meetings, because I didn't know what it was when it came in the mail. And then my friend was like, oh yeah, it's for your Zoom meetings. And I'm like, and I just constantly have them on my fingers for some reason. And then now in certain Zoom meetings, I'll just be like talking and just sort of, sorry, it's a reverse. I'll sort of just do this and be like, oh, how are you? And people are like, what the hell is that? So that's what it is. It's a weird squirrel finger puppet thing that I just play with. And that's that. So, all right, real quick. I see one last question. Skyla, please don't hate me. Shania, I hope I got that right, at 8:02 p.m. Can avoidance of getting medical help be a compulsion? Avoiding going to doctor or avoiding a CT scan that was recommended? Absolutely. Absolutely. It can be 100%. Just as much as people want to seek it out, people are scared of it for, whatever reason. The fears are valid, and obviously you can see where that could be problematic as well. And so 100% it can be a compulsion. It's always important to work with your treatment provider to determine, if it is in your case. And obviously, if there's a medical reason for you to get a test, and it is recommended by a doctor, then you should. But yes, it can definitely be a compulsion as part of an overarching OCD subtype or symptom. So, all right, let's wrap this up. First of all, I want to thank the IOCDF and Skyla behind the scenes for keeping the lights on. Also, thank you, Skyla, for posting all the links, as well as the skin picking disorder link. So if you were interested on that, make fists. I like that. That's a great idea. And Deirdre knits too. Blah. What was I saying? Okay. Tomorrow, join Chris Tronson for Ask the Expert. Ask the Experts. You can submit questions ahead of time on social at IOCDF or online at iocdf.org/peace of mind. Reminder, there'll be no new live streams from July 1st to the 11th due to the annual OCD conference taking place during this time. You can join us back on Tuesday the 12th for community conversations. So we don't miss me. I'm back. So keep that in mind. The 1st through 11th, there'll be no programming online. If you're in need of programming, if you need support, if you're not going to the Denver conference, all of these are recorded. We have 2.5 years of programming on Facebook, on YouTube. I'll give you some links. Watch away. We are still here for you in recorded spirit. Also, pre-registration for the annual OCD conference ends Thursday, June 30th at 3 p.m. Eastern. After that, on-site registration will begin Thursday, July 7th, 2 p.m. Mountain Time. You can learn more and register at iocdf.org/OCDCon. Lastly, this live stream is one of many. You can see the entire schedule of future live streams at iocdf.org/peace of mind. Thank you for the OCD Con link, Skyla. Sorry to jump so fast ahead of you. You can go to the IOCDF's YouTube page at youtube.com/IOCDF to check out all the recordings. Also, if you want to be notified of when we're going live, you can follow the IOCDF on social media and subscribe on YouTube. And as always, if you need resources, please don't hesitate to visit the IOCDF at iocdf.org. Lastly, my email, I'm sort of caught up. I did a huge batch. I answered like 30 people and it was awesome. And then they all replied. And I was like, crap. So if you're one of those replies, I see you, I read you, I promise I will get back. This is my email address. I always answer you. I'm the only one that sees this, even though it's an iocdf.org website. So if you want to talk more, if you have ideas, if you didn't get your question answered, if you have additional questions, if you need resources, I am here. Email me, just ethan@iocdf.org. Give me a few days. I will definitely get back to you, though. I always respond to all emails. With that, thank you so much for spending your Tuesday evening with me. Have a wonderful evening. Stay safe, stay vigilant, feel the feels. If you see me at the conference and you're there, run up to me and say hello, please. And that's it. Don't let OCD off the hook. We're in this together. Have a beautiful evening. Good night.